Right. Let me get these slides up. Good afternoon, everyone, and welcome to the February 8th edition of the Provider Update. Thank you so much for joining. And on the call today, we do have Dan Burke, the Infectious Disease Bureau Chief, and I think Joelle Jacobs is also joining us. Lots going on for vaccines, so she'll be available to answer questions and keep me honest. Okay, so starting in on just our COVID vaccine overview, and I really just keep this timeline here so we can all appreciate all the vaccine changes that we have been through in this, and you know how the font keeps shrinking. Most recently, as most people are aware, Moderna's Spikevax got approved. Can't remember. I think that was happening like right at our last call, and then it did get endorsed by ACIP and signed off by CDC director. And one of the things I learned recently is the full approval. We are still supposed to follow the rules around this vaccine set out by ACIP and CDC, but it does allow the CDC to write emergency use instructions, which are slightly different recommendations around vaccine use. So again, this is probably old news to some people, but I just learned that last night. So in terms of just our overall COVID picture, we still have high levels of community transmission across the US, although those numbers are coming down. I think it's just going to take a while until we get into other colors than red, but you can see a few spots showing up of blue and yellow. The case rate, this is national data across the US, has come down, although 660 cases per 100,000 still pretty high. And the 7-day positivity also much lower than it was last week, so at 17% now. This is New Mexico specific data, and just seeing that same high peak or sharp rise and sharp decline that pretty much every jurisdiction you look at, this is what Omicron does. But nice to see that it's happening here in New Mexico. And if you've been tracking the daily case rates, you can see that indeed it is coming down, although we're still sitting at a fairly high number. The other really good news here is that the infection rate is at 0.8, so that's the R effective. We've been kind of tracking that on this call, and this is the lowest it's been in quite a long time. So again, implies hopefully a shrinking infection. I thought this was interesting. This is also from COVID Act Now, but this data in various iterations is in many places, including DOH specific on our website. But this is looking at deaths, and I think that continued conversation about Omicron and potentially BA2, its little sister, is just a less virulent variant is true, and yet look at the death rate here. So but this is kind of our Delta surge here in December, and then here is our Omicron surge. Kind of starting. When did we start? Like late December, early January. So just to kind of remember that, especially in the unvaccinated, it still has a really serious consequence. Just the sheer number of people who got infected, leads to so a lower percent, but still a large number of deaths and a large number of hospitalizations. So good news, we see a downward trend in hospitalizations. But again, look at these numbers for our Omicron surge. So that's just a way of saying go, go, go on the vaccines. On the vaccines, we don't have such good news. We've been tracking this kind of decrease over the last few weeks, really since the holidays. For this time period, end of January, we still had 35,000 vaccines that were given across the state. You can track it on the dashboard, the vaccines given in the last 7 days. and it's down in the 20s now, which kind of reflects where we were, or same as where we were last summer. This is our just tracking by race and ethnicity. And again, I really do update this every time we have this talk, but it really looks the same and really hasn't changed in weeks. We still see the disparity across the state in our Hispanic and African-American communities. This is looking at, we've shown this slide before, but we were tracking the first doses just to kind of see how the rollout worked. So one of our, Nathan Wynn, one of our data analysts from the CDC, decided to take a look at the second doses, and it looks largely the same. We are seeing the blue line is the 5 to 11-year-olds. We're seeing less of an uptake across the board than we did in our 12 to 15-year-olds. But I think the other thing that's concerning and worth tracking is just this, what looks to be maybe a widening gap between first and second doses. So kids got their first dose, and it seems like the uptake on even just that second dose maybe not as good as it could be, or not as good as it was in the 12 to 15-year-olds. So maybe a little too soon to tell, but we need to keep an eye on that. We also, we can circle back around to that when we talk about our next age group. So on my vaccine watch list, we do have the Pfizer 6-month to 4-year-old, which we'll talk more about, but just to remind everyone, it will be a 3 microgram dose. It is a maroon cap, and it probably will be a 3-dose series. Although, and again, others can chime in on the call, it looks like the initial emergency use authorization request will be just for those first 2 doses, which looked very immunogenic in the younger of that age bracket, but not so much in the 2, 3, and 4-year-olds. The VRBPAC meeting is February 15th, so this is happening, or at least VRBPAC is meeting on it on February 15th. And then, as just to remember, like there's VRBPAC, which is the Vaccine and Related Biologics Committee of the FDA. Then FDA has to sign off, then ACIP meets on it, and then CDC director signs off. And then our MAT team signs off as well here in New Mexico. The booster interval for immune compromised, and interested to hear from other people on this call. It was definitely discussed at the ACIP meeting that happened February 4th, I think. They proposed shortening to 3 months after a 3rd dose in the immune, so shortening that booster interval from 5 months to 3 months. And that is sort of where I learned about this emergency use instruction, that's something that they could do now that Moderna has been fully approved. I think this really is happening, but I just haven't seen an official communication from CDC on it yet. The mRNA dosing interval, ACIP is also looking at 8 weeks between dose 1 and 2. That probably isn't it isn't quite as imminent as this shortening the booster interval for immunocompromised people. The PEDS Pfizer for 5 to 11-year-olds, again, this one is in more in the future, but it does look like they are looking at a 3rd 10 microgram dose. There's 2 Omicron specific vaccines, Moderna and Pfizer, both studying one. So again, these are in the future, but just to reassure ourselves, we'll stay busy in the vaccine world. And then Novavax, which we've talked about before, but nothing new on that. On the vaccine updates, we do have, and again, Pfizer does send this slide, and then, it's really just for planning purposes. It's not official because this has not been approved, but here's our maroon cap vaccine, which will need dilution like the orange cap. It will be a 0.2 ml dose, which is 3 micrograms of vaccine, 10 doses per vial after dilution. And we'll have the same specs as the orange cap. So in that way, it will be easy, but it is different from the gray cap adults. And then I might pause here for Dan or Joelle, if you're on the call, to just explain about the survey and some of the ordering. I don't mean to put you on the spot, but.
Sure, I can jump in.
Thank you.
So in anticipation of the Pfizer pediatric maroon cap vaccine coming out and being approved, similar to what happened in the fall when we were looking, when we first started getting our Pfizer orange cap, we will do preliminary orders so that vaccine is on the ground before the approval, so that as soon as everything is approved, providers who have the vaccine can start administering. So if you all could take time today and over the next couple of days to fill out the survey. It's very quick, it's only 2 minutes. This will help us to plan out who's going to receive these first preliminary orders. So to make sure that we have enough around the state, we don't have unlimited supply at this time. So we want to make sure that we have enough around the state just for these first few waves that are going out. The minimum order to order is 100 doses. So make sure that when you're putting that in there, you're ordering at least 100 doses minimum. These first waves will go out, shipment out on the first of, on February 21st. So please remember, February 21st is President's Day. If you are going to be closed, please make sure you note that. You can note that in the survey, or you can send me an email. We don't want vaccine being shipped out if your facility is not going to be opened. We'll make sure that you get out in the second wave, which will be delivered on February 22nd or after. We anticipate that normal ordering will be done through NMSIS starting after February 25th or once a week after CDC approves. So that time will fluctuate. As approval is being done, we'll try to update you guys as much as possible. We'll keep you updated on any changes in shipping. And then as well as if we're not able to provide your full doses, we will also let you know those as well. You will also receive all of your ancillary supply kits with this. So this will come with the diluent and any ancillary supplies. If you do not want ancillary supplies with your vaccine, please also note that in an email or in the survey so that we can have those held back for you all. Thank you.
Awesome. Thank you, Joelle. And she cut, I imagine this is for all vaccines, just that heads up that Monday is like February 21st is a holiday. So especially for this new vaccine, but also for any, we just remember that you don't want a delivery on a holiday if your organization is not open. And Joelle, just to clarify on the survey, are you looking for one answer per organization, basically? Like it kind of whoever's organizing vaccine, or every provider to do it?
It would be helpful for every provider, because then if you're not going to provide that vaccine, it will let us know, so that when we do send out information, we're really trying to target just those who are providing it. If you're not going to provide it, that's okay if you don't fill it out either. But we definitely know if you are going to fill it out, please fill out so that we can at least make sure we get your orders in. That is what's most important about the survey, so that we can make sure we get those orders entered and to you guys, so that once everything's approved, you can be administering vaccine.
Okay, and it looks like you are really starting now. I think you told me we had an allocation drop into your system today, right?
Correct. We did get our first wave of our allocation. So if you could fill out that survey as quickly as possible so that we can start getting those orders processed. So the first waves will be done through this Friday, and then second waves will be done through next week. So we'll leave the survey open for the next couple weeks. But the soonest you get it in, then we can start making sure we have getting vaccine to you.
Great. Awesome, thank you. And yes, spread the word, because obviously this is a different way of ordering than through NIMSIS, which it can't be a NIMSIS until it gets approved. So, all right. And then you're on a roll, Joelle. You want to just talk about J&J, and the rest of this I think is not new.
Sure. So J&J, CDC is going to be moving away from J&J vaccine in the foreseeable future. So due to that, we don't have unlimited supply anymore. So supply is very limited at this point. So if you are in need of doses, or you have J&J doses that you no longer are going to use, please just send us an email to the COVID vaccines email, so that we can move doses around to providers who are still utilizing that. If you are a provider who is using J&J, we do recommend that you need to start transitioning over to an mRNA vaccine, which is Moderna or Pfizer. So again, just being prepared in the future that we will be moving away from the J&J vaccine. Another thing
Joelle, do you know if that, like, will that be orderable on the private? Well, I guess it never got fully approved, right? So is it really just going away, do you think?
At this point, and we're still all under looking at it under the EUA, it will be moving away from us to be able to offer it under the COVID vaccine program.
Okay.
The other thing to please be in mind is that you're double checking your orange and gray cap expiration dates. Remember that these also are in the ULT for 9 months, or they go in the refrigerator for 10 weeks. So please make sure you're updating in NIMSIS for the 10-week expiration date. So you'll have to make that adjustment in NIMSIS because it'll automatically give you the 9 months expiration. So please make sure you're updating that 10-week expiration. This helps us on our side to identify how much inventory we have, when the vaccine is going to expire, so we don't let doses expire if we can move them. CDC is tracking all of our inventory, so this will help us make sure that we know exactly where doses are and how much we have left before they expire.
Awesome. Thank you so much. The other two things on here, I think we talked about last week, the immunization gateway. So that just means in NIMSIS, we are slowly connecting with other states, with the first ones being Nevada, Kentucky, and Oklahoma. And then for all things vaccine questions, concerns, that covid.vaccines@state.nm.us is your one place to go, an email that will get answered because the whole team has access to it. All right. So I left this slide in from last week. I'm sorry, it looks horrible, but it was such a, this kind of answers the question that we sent up to CDC about those people who kind of missed their third dose of Moderna and got a half dose instead. So basically they are just gonna, kind of start over that half dose given at the wrong as a booster, but should have been a full dose. Third additional dose, just start over and give that third additional dose, and then they march forward. I also left it in here to remind me, and we did talk about it, that more than likely that booster interval is going to shrink to 3 months rather than the 5 months that it is now for this group, for the immunocompromised group. Just to keep things interesting. I also saw that they discussed some different options for Johnson & Johnson. So, I mean, hopefully we'll have a little bit more clarity this time next week. In terms of mask wearing, we just thought, this is from the MMWR, but just a really interesting graphic that wearing a mask lower the odds of testing positive by, quite a large amount. And so here's, as you have increasing quality of mask, a decrease in the chance of testing positive. For testing updates, I think we talked briefly about this last time, but Chris Schroeder and team did a revamp of the findatestnm.org. So now you enter your zip code and it kind of narrows down both choices for ordering home tests. It will show you the places that you can go pick up home tests in your community, if they're still available, those are going fast. It connects to local pharmacies and also allows you to see some of the just standard community like curative testing sites. So that has been, I think getting good reviews from people for just ease of use. Our Project ACT, which is Access COVID Tests, another mail order program, again, sponsored by the Rockefeller Foundation for our first month. We had actually very low uptake on it. We had limited it to high SBI zip codes. Still hoping that group will find this website, so any community messaging you can do would be great, but we did expand it so it's available to all zip codes. So if you go to the website, the findatestnm.org, and put in your zip code, the first thing that pops up is this option to order through the Rockefeller Foundation. So, this is good if you've got staff who need to test, or teachers or patients, or, I think this is a good option, although it is limited. Once we hit 35,000 orders, that this program will be done. The state is looking at paying for a phase 2, but those come fairly quickly. The other part of the home testing program, we are trying to get into place and are very close, a standing order for home tests. So we know that insurances will reimburse people for 8 home tests a month, but obviously that's still a large out-of-pocket cost, especially for Medicaid and some Medicare participants. So this will allow someone on Medicaid to go to the pharmacy, ask for a home test, and basically have it dispensed through the pharmacy. The patient doesn't have to pay out of pocket, and the pharmacy is able to bill Medicaid. So this will be open to all insurances. It definitely gets more complicated with some of the other insurance plans, but hoping to have that in place in a few days. And it does look like supply is getting better in some of the Walgreens and CVS's. The shelves were bare for a while, but we're starting to get reports that that tests are back in stock. So another option for people getting vaccine. Reporting of home test results is still optional in New Mexico. And in fact, you can only report a positive test. You cannot report a negative test. This is the link if people are interested in reporting their positive test. And this is what it looks like when you click on the link. And then there's a second option, which is nmnotify.org. You can also put your positive home test in there. It's this bottom choice here. This does not go into any, this information does not come to the state, but it does. This is the contact tracing app. So if you put your positive home test in there, it will notify your people you were in contact with, at least according to your phone. The other thing I just wanted to mention about this this website, where the state can see the positive home test, is that this still doesn't go into our daily case count. So we're aware that this is a different level of data. So I think there were people who felt strongly about being able to report their data, and it will get looked at just to see kind of how many people are interested in reporting, and we have like 1,800,000 tests, home tests that have been distributed, and that's not including the federal supply. So it is interesting to see how many are in use and how many are testing positive, but it's not going into the case count. For a therapeutics update, I just wanted to, I don't know if Liesel's on the call, but she made this very simple, lovely flyer about the 4 choices of COVID-19 treatments. We can send out the PDF if it would be helpful. If you feel like there's places you would want to post it or patients you would want to give it out to. It is really meant to be simplified to give a high overview. It doesn't get into details about your renal function, But again, overall uptake of oral medications in the state remains low. So trying to message both to patients that it's an option. If you do a home test and you're positive, reach out to a provider to explore the question of oral therapeutics. This is old, but just to look at again, the Paxlovid was on the rise, but still we're not getting through all of our supply. We are looking at trying to get some of our oral therapeutics to FQHCs that have in-house pharmacies. That might help decrease some of the barriers. But again, any provider in the state can prescribe to this community a Walgreens pharmacy, and they will ship to your patient. But again, it is somewhat difficult by the time the patient gets in and you make a decision, and there's only a 5-day window. So there's a lot of challenges. And really interested in any feedback you can provide about, ideas about increasing the uptake. This is again the OMAS score, just to try to mostly in use now for our monoclonal antibody sotrovimab, which is very limited also, and Paxlovid. So you do have to have a score of 3, but that's basically anyone 65 and older with any, medical condition, or someone who's a little overweight and a medical condition. So not hard to qualify at this point. And then these are just, again, our contact information for providers. These are the ones for patients. And I think that is it for today on the slides. Thank you so much. And we can go to questions, or let me turn it to Dan and see, is there anything?
No, I don't have much to add. The only thing to say is that I took a look at that survey that we sent out, and you should be able to do it in 2 minutes. It's super quick, so don't worry about that. And also, I emailed it before the meeting, so it should all be out there. I see a couple people asking for the PowerPoint to go out, and I know Chris can probably get that to folks if you're on the mailing list. So that's all I got.
All right, one other thing, and I have to say, true confessions, but I did I think IHS emailed out to their providers, their CMO, Dr. Loretta Christensen, who is previously worked in Gallup, but an update. And so she also mentioned that the restriction on having to wait 90 days after monoclonal antibody had also gone away. I did see that in the slides, but again, I guess I'm feeling like, I haven't gotten anything official except from Dr. Christensen. So I'm sure it's coming, but just want to kind of put that out there on your radar, and we will, message out when we kind of get the official word that we can change and incorporate those recommendations. But I myself am very happy. It's never completely made sense to me about the monoclonal antibody, but it also was just always a little bit of a hassle to keep track of that. And so now we don't need to worry about that. Well, I should say soon we should not have to worry about that. All right, what questions? Let's see. And Tanya, I saw you had your hand raised, so do you want to unmute and?
Thank you, Dr. Durham. My question's actually for Joelle. I don't know if she's, yep, it looks like she's still online. So when they start rolling out the 6 months to 4 years, is Pfizer going to shut down their other delivery like they did for the 5 to 11? I'm trying to empty my freezer right now because you're supposed to do a once a year clean out and service. So I'm like getting way down low on supply. So I can get a company in and do that, but I want to have it back up and running, but that'll be about around the time I need to order regular Pfizer as well. So I'm just trying to time that if they're going to be holding, or if you know.
At this time, we have not been notified that that will be an issue. Again, things are changing rapidly daily here. So as soon as that if we get notified by that, I'll let you know as soon as possible. But otherwise, just send me how much you anticipate you think you're going to need, and we will come up with a solution on the side if that does happen. So.
Thank you. And I'll also be more than willing to hold vaccine for people who don't have ultra lows if they need me to. And yes, the ACIP meeting was very confusing. I heard J&J multiple shots, tell them to get mRNA, but give them extra shots if they want to stay with J&J. And I'm like, but it's going away. So it was very confusing ACIP meeting.
Yeah, I mean, my takeaway was that it'll be J&J recommend the mRNA, and that it'll probably be that they get 2 doses of mRNA.
As a provider, I get some people that are like, sure, I'll go to mRNA now. And I get others that literally cuss you out for even mentioning it.
Yeah. And I am sure, I don't know what's going to happen with Novavax in terms of mix and match. It's probably going to be a while, but I do think hopefully that will be, that will kind of fill it's not the same as it's not a viral vector vaccine, so not the same as J&J, but I am hoping that it will, I guess, appeal to the same group of people, there will be a group of people that will feel comfortable with that vaccine that have not ever gotten comfortable with the mRNA. But who still lots of steps away. I mean, and Joelle, there's a question: if the survey has been submitted, does that mean we may potentially receive maroon cap vaccine without placing an order in NMSIS?
Correct.
And that's a
Yeah.
yes. Okay.
Yeah, this just for these first 2 waves. Again, ordering, we anticipate it to be up and running in NMSIS about a week after CDC approves. So we're looking at towards the end of February, after February 25th. Then you'll be able to order as normally.
All right. And Jasmine, we will, I think if you're on the invite list, I think another way with the slides, she's saying it can sometimes be hard to access them on the website. Let me just try doing a PDF of them and sending out to this group. I can send them. They'll also be on the website. And hopefully, I think the main, really probably all anyone wants is that lovely little chart that Pfizer puts out about their different brands. I was like, yay, they added the maroon cap. Okay, do manufacturers have any plans to implement pre-filled syringes in the future? I don't think any of us know. I mean, I know we sometimes get to meet with the Pfizer team early on, had kind of a pilot project with New Mexico. And so, we do sometimes chat with them, and we do always pass on the, that fewer doses and more easy things like pre-filled syringes would be helpful. And they always say they hear us, but my guess is it'll be a little ways away. Oh, and Dan, sorry, Dan already answered that one. Okay, is Project Axe sending Binax Now tests? And so no, it is actually also sending iHealth, which is just a coincidence, but there's 5 in a box. So I'm not sure if it's that same orange box or not. Okay, and then yes, another call for the slides. Could I be added to the mailing list? Chris Schroeder, I will let you take that one. There are a few more. Can I be added?
I'm sending all those emails to Chris. So
Awesome. Okay.
can't thank me, but yeah, here we go.
I think the CDC will do away with the required observation period, especially after the primary dose. So like for dose 2 and booster doses, this would facilitate us vaccinating. I think it is a great question. And I think practically lots of us have sort of observed that at least patients are, if you don't tie them down, they tend to walk more quickly after the booster than they did before. But yeah, I don't know, Dan or Joe. How long do people remain COVID positive after testing for COVID? Are we screening for testing positive before administering vaccine, or are we just asking, are you sick today? So on how long people test positive after having COVID depends a little bit on what kind of test you use. With a PCR test, it at least, and I haven't been tracking it as closely with Omicron, but in the past, there were people that were testing positive months after they were fully recovered. For the rapid antigen test, they really shouldn't be testing positive for a long time. It's much more related, a positive test on a rapid antigen is much more correlated with viral load. In terms of screening for testing positive before administering vaccine, that isn't a recommendation, and the reason for that is that it really isn't harmful to the patient to get vaccinated. I don't think it's a best practice, but it doesn't cause harm. Where it could cause harm is to the people vaccinating. So I think there is the question, like, are you feeling sick today? And, for many different illnesses, if someone is running a fever or feeling ill, it's probably not the best time to get vaccinated, especially if you have the bad luck of having a lot of side effects on top of your illness. That isn't so good. And yeah, hopefully that answers the question. So there is some judgment there. But I don't think as a vaccinator, you have to feel like you are doing something bad if by accident if someone comes and says they're not sick and it turns out they test positive for COVID a few days later. Let's see. Okay, someone's giving feedback on the probably something I clipped from the internet and didn't notice on the Paxlovid box. So thank you for that, and I'll go back and look. Let's see. Have you been hearing of false positive flu A and B rapid tests instead, in spite of flu present moderately in New Mexico? So I don't know if one of the things that we're referring to, like the school test to stay program, the contractor PMG does tons of rapid testing in school settings and ran short on supply, so ended up replacing a COVID only test with a COVID flu A/B combo test. And so in general, and those were rapid antigen tests. In general, rapid flu antigen tests really don't have that great specificity and sensitivity. So, and what happened is, because people were having to test for test to stay, asymptomatic people were being tested with this triplex and getting a flu test. So this is a conversation kind of going on in epi, the idea of asymptomatic flu. It's just really not something that like clinically comes up that often, because normally you wouldn't test someone for flu who didn't have symptoms and you weren't thinking about providing medication. But yeah, probably it is possible to have your flu shot and kind of have enough virus to trigger the test. And it is also certainly possible that there are false positives and false negatives from any rapid antigen flu test. They vary quite widely, and honestly, I was not able to track down the specs on the test that PMG was using. So anyway, that all that is kind of conjecture on my part, and hope that answers the question.
Yeah, so our rapid tests are the Sophia Quidel, and so we can do COVID only, or we can do COVID with flu A and B. And in the summer, at first we only had the triple cartridges, and in the summer we were getting quite a few false positives. We did a few follow-up tests, and nobody that was positive on the rapid test was positive on the PCR. And we thought, well, the prevalence in the community is super low. And so that makes the false positive rate, a bigger risk. And so we didn't really pay attention to the flu bees, in the summer and the fall so much. But now we've been also getting, some positive flu bees as we're testing to allow people to come back to work early. And so we're just trying to decide whether we have to, PCR test everybody or what we should do. But it's reassuring to hear you say that people aren't thinking that asymptomatic flu is very likely. So we should probably trust our clinical judgment if people are recovering and actually doing better.
Yeah, and I should say, I mean, it may be, maybe, I just think asymptomatic flu, I don't know how common it is, but it just isn't something that, like in the past years when we didn't have COVID as sort of the driver for testing, that we really paid attention to. But the flu rules have kind of always been, more like, 24 hours without a fever, you can come back as long as you're not coughing up a lung, or, actually we didn't do too much masking around flu, but that would certainly be an option. Also, I think is just asking people to, mass work for preventing flu spread, as well as we found out last winter when we had super low flu rates. So, okay. And Una Smith is saying CDC is reporting flu in New Mexico is high. And yeah, Una, is that something that you track? I always find one of the things that's interesting, and I'm definitely not an expert on the flu surveillance program, but just that one of the things they track is influenza-like illness, which is a symptom constellation, which is also similar to COVID. So I don't know, I might need to figure that out a little bit, like what's actually getting reported on the CDC website. All right. And yes, we will put the slides on the Take Care NM website. Are there, oh, thank you for the flu source. And then I think the Epi department has an NMDOH one as well. So.
Yeah, I agree that ILI is really confounded by COVID. I just think it's really hard to separate them out. So I'm not sure how meaningful ILI becomes as a measure anymore. Not being an epidemiologist.
Right. But if it is an interesting topic, we do know some very good and very nice epidemiologists that we could have come next week. And that might be a nice change from all this COVID talk.
Excellent suggestion.
All right. Are there any, please, if I missed any in the chat, please let me know. It looked like, I think Dan's got all the people who want to join the mailing list. I will,
Yeah.
I'm going to just reply to the mailing list with the slides, and we'll also post them.
Yeah.
And
Miranda, we probably just want to kind of do a little bit of a plea, which is that, this 6 month to 4 years through 4 years is going to be a bit of a challenge for a number of reasons. So it's, I think it's up to each of us to do as much as we can to reach the patients who know and trust us, because I think there's going to be really a lot about how much parents feel trust and to get their kids this vaccine. So it's going to be a challenge. So let's do the best we can and reach out as much as we can and see situations that might work. And we're looking at all kinds of different ideas, including private providers or pediatric providers, family practice providers, maybe being able to augment their vaccine capacity with some of our contractors. So that's one of the ideas that got thrown out. Something to certainly consider if there's capacity issues to to give COVID vaccine for the little guys. So
yeah, good point. And we did talk about it a little bit last time, just the fact that pharmacies are not usually vaccinating under 40 years old. Those are their corporate policies, and we haven't seen any indication of change. So we really do lose our pharmacy partners in this, and that will then come back to primary care settings. And there are about 108,000 kids, 6 months to 4 years old, just to keep that number in mind. We are kind of expecting a pretty slow roll, just as we saw with 5 to 11-year-olds, less uptake than with the group above them, and that was less uptake than the group above them. So I think it will be a challenge. But there's always that group at the beginning that are chomping at the bit. And so, we also do want to be prepared for them. And, it's nice that CDC and our immunization program are really working hard to get that vaccine on the ground for when it does get approved. And I put my email in the chat if people have ideas about like any of the things we discussed on here, but especially on getting our newest group vaccinated, please let us know. Yeah.
Hi, this is Carol from the Southeast region. This question is actually for Chris. We sent him, Susan, my nurse manager in Eddy County, sent him up some screenshots, and it's regarding, if Chris could answer, it's regarding the lot numbers. We have a huge amount of lot numbers that are inactivated, but they're still showing up. Can anything be done on this end, on his end, to be able to either get rid of those lots, to hide those lots? Because it's causing some issues when we are administering.
Hey, Carol, this is Chris. How are you? Yes, I'll bump this back up to the top. It is in the queue. We have a lot, obviously, in the queue, so I will bump it up to the top, and I'll get back to you by the end of the day with where we are with that.
Thank you, Chris.
Of course.
I also did want to just call out Jasmine Meyer. Thank you for your like more cheerful take on the vaccinating kids. We've seen good numbers in our peds patients so far and hopeful for the younger ones. But I also do want to say that on multiple, Presbyterian just did a quick survey of 300 parents of unvaccinated children on national surveys on the one through UNM. Survey after survey really shows that again, trusted providers and interestingly, even providers who have gotten their own kids vaccinated and are willing to talk about that are really moving the needle. So all the I think Jasmine, I'm blanking on where you work, but I think those kind of medical home models or people in the community, like our FEMA teams and our nurses that have been contracting with those mobile teams that have gotten known in the community, or like Tanya and Corrales. I think those settings, our PHOs, the list goes on, but all of you, what you're providing is kind of that trusted, safe place. And again, over and over and over again, that's what makes the difference when parents are surveyed. So not surprising that that at La Familia in Santa Fe, they're seeing, a higher uptake than kind of my across the board slides are showing. So thank you for that. And thanks really to everyone for, providing that safe environment. I should put the IHS in there as well. So All right. Anything else from anyone? All right. Well, again, thank you so much for joining and spending your lunch with us. Every week I say this, maybe we don't need to meet next week, but I do think actually there probably will be some new things in vaccine and just tracking this rollout of the PEDS vaccine. So anyway, we'll be here and hope you are too. And please reach out in the meantime if there's any questions. Thanks. Bye.